We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to The Pinch of Salt, a podcast brought to you by the ERA. I'm Dr. George Kosmadakis, your host today, and the subject is Obstacles for the Development of Peritoneal Dialysis, a Solution Toolbox. It was inspired from a wonderful presentation by Professor François in the ERA Congress. I was really amazed to hear her, and I wanted to invite her to share with us her personal experience with all these solutions. Because despite its proven benefits, peritoneal dialysis remains underutilized in many parts of the world. Barriers range from structural and logistical issues to patient and physician perceptions. Yet, with the right strategies and innovations, peritoneal dialysis could become a more prominent part of renal replacement therapy, offering patients more flexibility and potentially better outcomes. So we are delighted to discuss these challenges and solutions today with our guest, Professor Karlien François from Brussels in Belgium. Karlien, welcome to the Pinch of Salt.
Thank you very much, George. Thank you so much for having me.
Thank you. The honor is ours. I will start straight away with the first question, which is always a naive question, but not so, I think. Why in 2025, 45 years after the introduction of peritoneal dialysis, we should always discuss about the importance of peritoneal dialysis?
Well, yes, a good question indeed. Peritoneal dialysis is a dialysis modality, first of all, that offers good metabolic and good fluid status control of our patients with kidney failure. And it offers these dialysis goals at several benefits. When we look at or when we think about benefits of dialysis modalities, of course, a first outcome we think about is survival. And there we can say that overall survival is generally considered similar between peritoneal dialysis and center hemodialysis. So this hardest endpoint in clinical trials might not be the argument in favor of one dialysis modality or another. And if quantity of life is not so different across dialysis modalities, we should acknowledge the impact of the dialysis modality on the day-to-day living of our patients, on their quality of life. And there are truly some benefits for peritoneal dialysis. Of course, we know PD, it is offered within the home environment of the patient. It empowers the patient's autonomy. It allows flexibility in treatment scheduling. And all these factors led to the fact that the quality of life analyses of patients on peritoneal dialysis are really reassuring. When we look at the studies comparing quality of life between hemodialysis and peritoneal dialysis, at first sight, it seems that quality of life is rather driven by the frailty of the patient than by the treatment modality. But there have been several studies comparing quality of life between PD and HD, such as the BOLD trial and the FEPOT trial. And in these trials, matched patient populations between HD and PD were compared in terms of their quality of life. And these studies showed higher depression and illness intrusion scores in patients treated with center hemodialysis and higher treatment satisfaction in PD-treated patients. So as it is a home-based therapy, not surprisingly, the number of hospital visits is lower for patients treated with PD compared to center-based hemodialysis. So there is also less transportation needs for the patient. But PD also offers several other clinical benefits. The patient treated with PD does not require a vascular access. So there is no exposure to the risks related to central vein catheters or to the hemodynamic changes of AV access. PD is associated with a slow rate of toxin removal and slow rate of ultrafiltration, but this leads to a very stable hemodynamical treatment. So there is a very good hemodynamic tolerability of the treatment. And this leads, for instance, to the fact that there is no such thing as the post-dialysis fatigue, something that we often see in center hemodialysis. We also know that the hemodynamic changes during an HD session are associated to myocardial stunning and systolic dysfunction over time. But these cardiac effects have not been demonstrated in PD patients. The hemodynamic changes during a hemodialysis session are also associated with impaired cerebral blood flow during the hemodialysis session. So also these aspects might be really important for our patients. For instance, looking at the clinical outcomes, a large USRDS analysis recently showed that there was a significantly higher hazard for getting a dementia when patients were treated with HD compared to PD. And of course, we should not forget about the bleeding risk. We know that our uremic patients present with higher bleeding risk compared to non-CKD patients, but the bleeding risk is significantly lower for PD patients compared to HD patients. And this has been shown in different cohorts from different parts of the world. And from an organizational perspective, by its nature, PD reduces burden onto the medical teams in the hospital. So I think both from a medical perspective, an organizational perspective, PD is really able to offer clinical advantages to patients and to the society.
Right. So acknowledging all these benefits, better tolerance, better clinical outcomes, better quality of life, less burden for the medical teams. Acknowledging all these benefits, what are the main barriers to the wider adoption of peritoneal dialysis worldwide? Why it's not the main method of dialysis in the world today?
Yeah, good question. This question on barriers to PD adoption is a very relevant question. Also, because uptake of peritoneal dialysis differs across regions, across countries, and even across different centers. And so when we see that the uptake of PD differs so much around different centers, countries, and regions, it looks like the barriers might also be different according to your personal setting. So when we dive into the barriers of PD adoption, we see that these are multiple and they span across different levels, I would say. So there is the barriers at the healthcare level, the barriers at the dialysis center level, and the barriers at the level of the patient, him or herself. So at the healthcare system level, of course, first of all, it should be available. Whenever PD is not available, such as in different parts of the world, let's think about Africa, for instance, there is a much higher barrier regarding to PD availability. In that kind of situation, there is a huge barrier to adopt a peritoneal dialysis. But in higher income countries, availability of PD fluids and PD catheters might less be an issue, but their economical drivers might be an argument at the healthcare system level for or against peritoneal dialysis. And when we think about economical drivers, we think about reimbursement strategies, financial incentives or financial disincentives for home dialysis, and for instance also material costs. And then, of course, there is the healthcare policy. There are some countries in the world where there is a home dialysis first or a home dialysis preferred policy. And these policy clearly lead to higher uptake of peritoneal dialysis. Now, even in countries within countries, so between centers working in the same healthcare system, we see that there is a large practice variability in uptake of peritoneal dialysis. And so this shows that there is also barriers at the level of the dialysis center itself. And this is often related to the attitudes and biases of the physicians. We also know that center size plays an important role. And of course, center size is associated to experience, and experience might be associated to confidence. And there, I think it's also really important to make the point that the hardest part is launching your PD program, is getting started and having your first 10 to 20 patients onto PD. I think it's really key that we support small centers in getting them organized so they can grow, because once you have a larger center size, both the experience grows, but also the outcomes, the clinical outcomes improve. It has been shown that the outcomes are better for larger sized centers. And yeah, of course, at the dialysis center level, there is also the availability of nursing staff. Whenever there is a shortage in nursing, it might become more difficult to to give them the necessary education and so on. And it might be more difficult to get the organization running smoothly. And then lastly, at the level of the patient, an important barrier for home dialysis, of course, is an unsuitable housing. But there again, we see that centers with higher home dialysis use often are more creative in finding solutions for patients with without a home, or with let's between brackets unsuitable homes. But at the patient level, also patient education is key. So we need to make sure that our patients are informed about home dialysis modalities and about peritoneal dialysis. And whenever patients do present specific intrinsic patient barriers, such as disabilities, we can offer them assistance. And whenever there is a lack of this physical, psychological, or social support, it might also be a barrier for PD uptake.
Right. So now that we have identified the three main categories of obstacles, how do you think that healthcare systems and nephrology teams could possibly overcome these obstacles in the clinic, in the everyday practice?
Yeah, indeed. So it's always easier to define the problems, but then we need to go to the solutions. And as myself, I'm trained as a clinician. I'm not trained as a public health scientist or a health economist. So for the sake of this podcast, I'd prefer to focus on the clinical part and on the parts of the dialysis center level and the patient level solutions. And there, I think the first thing we should do is focus on training and education for peritoneal dialysis within the healthcare system. And so I think this podcast is a first step also to expand PD exposure. We as nephrologists, we need to offer PD to our patients. We need to train young nephrologists in PD. We need to train fellow internal medicine physicians, such as cardiologists, endocrinologists, urologists. So we really need to make sure that there is an environment, a PD-friendly environment. This will not say that we should put every single patient onto PD, but at least we should increase the awareness that PD is an adequate treatment for patients with kidney failure. And we need to raise this awareness not only within our nephrology community, but even abroad. So looking at the level of the PD program, I think it all starts with a successful and a sustainable PD access program. Of course, we need to offer our patients a PD catheter insertion before the patient can go on PD. So our PD programs need to ensure that we offer all eligible patients a timely PD catheter insertion. And there, two things are important. All eligible patients, so we really need to look who is not eligible, and actually only a limited number of patients are not eligible for PD. The large majority of patients presenting with kidney failure is a potential PD candidate. And the second important wording is the timely PD access. So we need to make sure that we can offer a PD catheter insertion within the time needed. And there, I always tell my students that we should stay aware that up to half of our incident dialysis patients start dialysis in an unplanned way. Even our patients that we follow up in our chronic kidney disease clinics might need to start dialysis in an unplanned way because of rapid decline in their kidney function. And so we need to invest in this advanced CKD care, but we still need to be ready and set to offer unplanned crash landers to have a timely PD access creation. And regarding PD access creation, so in my center, we offer patients either a laparoscopic PD catheter insertion by the surgeon or a percutaneous PD catheter insertion by the nephrologist. And studies from across the world have shown that the outcomes for both insertion strategies, so the surgical and the medical, are good. And actually, that centers that have these both strategies, this dual access pathway, these centers have more flexibility in PD access planning. It becomes more easy to provide this timely PD access creation. As a center, you're more agile, and you're also often able to provide PD access to different patient profiles, the obese, the crash lander, the one with the contraindication for general anesthesia, and so on. So structure your PD access program is really a first step in overcoming the barriers to PD growth. And of course, we need to train nephrologists in peritoneal membrane physiology. We need to train in preventing and in treating mechanical and infectious complications. And this training will lead to improved clinical outcomes of the PD centers.
Right. So you propose that the secret is to create a PD-friendly ecosystem, clinical ecosystem, that supports this technique with a good training and education program and an integral PD access capability program, which is very interesting and very specific. But you talked about the eligible patients, and this is very often a barrier because we have a lot of patients that have been excluded even before meeting the surgeon for various reasons that probably are based on bad clinical judgment. So I would like to know which patient population could benefit the most from this PD expansion.
Yes. So I think indeed, when I talk to colleagues, I'm often surprised by the kind of patients they argue are not eligible for peritoneal dialysis, which in my center we do offer these patients peritoneal dialysis. And so I think about patients requiring an urgent dialysis start, so these crash landers requiring unplanned start of dialysis. I think about obese patients, anuric patients. I think about patients with a prior history of abdominal surgery. And of course, the very frail patients are also sometimes not offered peritoneal dialysis. And so maybe I can dive into some aspects of these different patient populations. Regarding the frail patients, it is really interesting because on the one hand, we see that a large proportion of our dialysis patients are either elderly or either frail. And studies have shown that whenever the nurse or the physician scores the patient as being frail, that the likelihood that this patient is offered a home dialysis modality was significantly reduced. So it looks like we have an intrinsic barrier of not offering these frail patients peritoneal dialysis. And this is actually, I consider this a little bit a strange reflex, because do we really think that we will take better care of these frail patients by putting them in a car and bring them to the hospital 3 times a week? And do we really think that we cannot offer them good care and that we cannot offer them caring for in their home environment because of their frailty, while they were living somewhere already? So I find this an interesting reflex. And I think there are several solutions with respect to peritoneal dialysis. There is assisted peritoneal dialysis. So peritoneal dialysis can be done using or with the help of a nurse, or with the help of a caregiver, or with the help of a specific device to do the handling of the PD exchanges. And also in these frail patients, we might consider, of course, whenever there is a true indication for a kidney replacement therapy, we might consider to offer them incremental PD. So maybe we should not offer these patients the high goal clearance targets, but we can offer them a lower dose PD in relation to their specific care goals. Also, these unplanned starters where I was talking about, so these patients can be offered PD, and actually there are several trials and even randomized controlled trial data from Asia that show that urgent start peritoneal dialysis compared to urgent start hemodialysis is associated with less catheter insertion related complications, with less dialysis related complications at 6 weeks after dialysis start. And so urgent start PD is a truly a good solution for patients presenting as a crash lander. We only need to take into account some general rules when prescribing urgent start PD. It should be done in the supine position using low volumes. It can be done either by doing a cycler, a machine, or CAPD, but always supine and using these low volumes. And maybe a 2 or 3 last words on the obese patients. So there again, we do have plenty of data that obesity is not a contraindication to peritoneal dialysis, that we can offer a safe PD access to obese people, and also that PD catheter patency is similar at 1 year between obese and non-obese patients. We also do have the data that PD is possible in patients with prior history of abdominal surgery. And actually, there is a very recent paper of the North American PD catheter registry that confirmed that history of abdominal surgery should not be a contraindication for peritoneal dialysis, because this study showed no increase in risk for PD withdrawal or PD catheter removal in patients with a history of prior abdominal surgery compared to those without a history of prior abdominal surgery. And similar data are also available from the UK, both for surgical and percutaneously inserted PD catheters. And then with respect to anuric patients, anuria is not a contraindication for PD. You can treat anuric patients with peritoneal dialysis, and this has been shown both with CAPD and APD protocols, for instance, in the ADAMEX trial and the EPOS trial. So there, in these anuric patients, of course, we need to adopt the PD prescription. We should focus on achieving sufficient ultrafiltration and sodium removal. But there we have the use of icodextrin, or the availability of icodextrin, that can truly be that can be very helpful in achieving the treatment goals in patients with anuria.
Right. So to conclude, as a last question, conclusive question, what solutions or innovations could form a toolbox for improving PD implementation?
Well, I think as you phrased it so beautifully, I really think we need to create this PD-friendly ecosystem, and I think such an ecosystem can grow whenever we offer training, whenever we increase awareness, and then these kind of ecosystems will grow by themselves. But because whenever we increase experience, we will also increase expertise, we will increase knowledge, and this ecosystem, this PD friendly ecosystem, will be a stimulating vicious circle. And I think the future is bright. There are several trials on the way exploring the outcomes of new peritoneal dialysis fluids. There are new cycler machines that are being tested. So I really think that there are developments on the way, and we should stimulate this research also in the field of peritoneal dialysis. And to be very specific for the center and for the listeners of the podcast, I would just support you in starting with some self-reflection. What works in my center? Because maybe there is several aspects of your PD program that go well. But try to identify what's not working, what are your specific barriers in your center, and then I think there are solutions to overcome these and to grow and develop. Yeah.
Right. So you finish with a very optimist note, which is wonderful. And that leads me to the last personal question, of course, as always. Karlien, if you were in a desert island, which book, luxury item, and 2 songs would you take with you?
Yeah. Well, so as I finished on the optimistic side, maybe this is because I'm currently reading the book The Bright Side from Sumit Paul Choudhury, and he's a scientist, journalist, and in this book he makes the argument that optimism is not the natural state of humanity, but actually it's our essential state of humanity. And so, to me, it's an inspirational book. And I think it will help us when we want to grow PD, but it will also help me whenever on a desert island. So then the luxury item, well, I play the flute, and I think it would be nice to have it with me on a desert island. Yeah, just to make some music. So I'd maybe also take along some beautiful scores of Mozart and Bach and Debussy. And for my two songs, one of my personal power songs is Rome Wasn't Built in a Day from Marchiba. So I'd like to take that one. And the second one is from a Belgian artist, Sylvie Kreusch. Walk, walk, walk. Just to keep on walking on the island. And actually, it's a song that really uh, is appropriate, I would say, whenever I'd be on a desert island.
Beautiful. Thank you very much, Karlien. It was a wonderful discussion. Dear colleagues, as you see, the challenges facing PD are many, but so are the opportunities. With a clear set of solutions and shared commitment, peritoneal dialysis can play a stronger role in the treatment of CKD patients worldwide. We hope you enjoyed the discussion as I did. Karlien, thank you very much for being with us today. Stay tuned for more episodes of The Pinch of Salt, available on all known platforms. Thank you for listening.